بسم الله الرحمن الرحيم. معكم دكتور محمد تركي، مدرس جراحة قلب وصدر كلية طب جامعة طنطا. النهاردة إن شاء الله هندي محاضرة عن الشيست تروما، وده يعتبر موضوع من أهم المواضيع اللي ممكن تقابلكم في حياتكم العامة أو بعد ما تخلصوا إن شاء الله وتبقوا في امتياز. هتشوفوا الكلام ده كتير جدا في استقبال الطوارئ إن شاء الله. لو جينا نتكلم عن الشيست تروما ان جنرال، هي بتمثل 25% من حالات الوفاة نتيجة التروما بتكون نتيجة شيست تروما. أنواع الشيست تروما ممكن منها بلانت تروما وممكن منها penetrating تروما. بلانت شيست تروما ممكن تكون نتيجة موتور كار اكسيدنت، ودي بتمثل حوالي 70-80% من البلانت تروما. ممكن يكون fall from height، ممكن يكون active violence، ممكن يكون blast injuries أو occupational accidents. penetrating chest trauma في منها low velocity injuries زي stab wounds مثلا بنايف أو ما شابه. ممكن يكون medium velocity injuries زي البوليتس اللي بتطلع من معظم المسدسات العادية، أو ممكن تكون high velocity injuries زي البوليتس اللي بتيجي من الرايفلز أو الميليتري ويبونز. injury 2. الشيست تروما فيها طبعا لازم نقسم الانجريز بتاعتنا لايه الجزء المصاب والإفكت بتاعه هيبقى ايه قدامنا في سواء كلينيكال او راديولوجيكال، وازاي يتعملوا مانجمنت. كل حاجه من دول بتختلف عن التاني. انجري thoracic كيج اللي هو بيتكون من الريبس، الكلافيكلز، السكابيولا والسترنم. او انجري thoracic organs اللي هي lung، pleura، tracheobronchial tree، esophagus، heart and great vessels، diaphragm. Associated organs may be also injured during the chest trauma, like head trauma، abdominal trauma. كل حاجة من دول ليها السبيشاليتي الخاصة بيها اللي المفروض تعمل لها مانجمنت في حالات التروما. Most common thoracic injuries are rib fractures ونيوموثوركس، الهيموثوركس، كايلوثوركس، ودي معناها ان الكايل بيتجمع في البلورا نتيجة التروما، بيحصل انجري للثوراسيك دكت، ودي بيحصل منها ليكج للكايل في البلورا وبيكون ما يسمى الكايلوثوركس. في عندنا كاردياك انجريز وفي diaphragmatic injuries. هنتكلم عن كل حاجة من دول بالتفصيل دلوقتي. Today احنا هنتكلم طبعا زي ما قلنا في الأول خالص important notes عن الشيست تروما و how to manage chest trauma. لو حد كلمك في الامرجنسي روم عن patient في شيست تروما هتعمل ايه؟ ازاي تقدر تتصرف في وضع زي ده؟ اول حاجة هتاخد history من البيشنت لو هو conscious، من اللي معاه، من الطبيب اللي قاعد في الاي ار اللي كلمك عن البيشنت، هتعرف منه البيشنت جاله بريزنتد بايه. لو البيشنت كان جاي كونشس وحصل فيه deterioration، الفيتالي ستيبل وحصل فيه deterioration برضو، الامور دي كلها لازم تاخد history من البيشنت، من الدكتور او من البيشنت او من الناس اللي معاه. بتشوف فيه associated morbidities ولا لا، تعرف سن العيان طبعا اللي ده بيفرق معانا في حاجات زي مثلا لو الناس الكبار بتتوقع injuries في حاجات معينة، الناس الصغيرين بتتوقع injuries في حاجات تانية. الاولد ايج هل في هايبرتنشن ولا لا، الناس اللي هم الاولد ايج والهايبرتنسيف دول متوقع فيهم لو في بلانت انجري ممكن يكون فيها aortic dissection، او ممكن يكون حسب برضو التايب والميكانيزم اوف تروما، دي تقدر تحدد لك ايه الانجري المتوقعه في الثوركس او associated بره الثوركس، ليكن ليفر، ليكن سبلين، ليكن هيد انجري. التايمينج اوف ذا تروما از فيري امبورتنت بالنسبه لنا. يعني لو عيان جاي مثلا بستاب ووند بقاله من الصبح وجاي لنا بالليل وجاي فيه الاكس راي فيها شويه كولكشن بساط، ده لحد ما بتبقى مش متخوف قوي ان يكون في ماسيف انجري جوه. لكن لو عيان جاي لك لسه ما فيش من نص ساعه مخبوط ستاب ووند وجيت تعمل اكس راي لقيت فيها كميه كويسه، فده تتوقع كميه كويسه مثلا هيموثوركس مجمعه، تتوقع ان يكون في انجري جامده للبيشنت. clinical presentation of the patient with chest trauma بتختلف على حسب ال severity of injury وعلى حسب ال organs ال damaged. قلنا ممكن تكون من simple pain إلى shock with hemodynamic instability. Presentation depends on the mechanism of the injury and the organ system injured. بمعنى ان احنا قلنا لو الاورجان ده حاجة just fracture ribs مفيش معاها associated injuries جامدة، ممكن يجي just pain، ممكن يكون just contusion للchest wall، وده برضو بيبقى just pain ما بيحتاجش management غير حاجات conservative بس، غير ما يكون injury جامدة وعاملة مثلا aortic injury، عاملة cardiac injury، عاملة tracheobronchial tree injury، وبالتالي دي اللي هيديك الفرايتيز في الكلينيكال برزنتيشن بتاع البيشنتس دول. لما نيجي نتكلم عن الدياجنوز fracture ribs، طبعا زي اي fracture في الجسم لازم هيكون في بين مكان المكان اللي فيه fracture هيكون فيه طبعا tenderness، وممكن يكون فيه crepitus بتاعت الاحتكاك بتاع الإيدجز بتاعت البون المكسور. ممكن يكون فيه flail chest. الفليل chest دوت عبارة عن 3 ريبس أو أكتر sequential حاصل فيهم fracture على more than 2 sites. بمعنى عندي مثلا الريب التاني والتالت والرابع مكسورين على الجنبين في نفس السيجمنت، فده بيعمل سيجمنت بتبقى اسمها فليل بمعنى ان هي مش سبورتد مع بقية الشيست وول، وبالتالي بتتحرك بالموشن بتاعتها مش مع الكونتينيتي بتاع الشيست وول كله. الموشن بتاعته بتبقى بارادوكسيكال، بمعنى ان طبيعي الانسان بياخد انسبيريشن الشيست بتاعه كله بينفليت بيديستند الشيست وول نتيجة ان الديافرام بينزل لتحت، نتيجة ان الانتركوستال ماسلز بتبدأ تكونتراكت، وبالتالي بيحصل ان الشيست ينفليت نتيجة الاكسبيريشن. ده نتيجة طبعا الانسبيريشن نتيجة النيجاتيف انتراثوراسيك بريشر اللي بيتولد نتيجة الانسبيريشن، ده بيتولد نتيجته نيجاتيف انتراثوراسيك بريشر. في العكس في الاكسبيريشن بيحصل انكريز في الانتراثوراسيك بريشر، وبالتالي عشان البيشنت يقدر يطلع النفس بتاعه لبره فبيحصل انكريز في الانتراثوراسيك بريشر، وبالتالي الشيست وول بيديفليت بمعنى ان هو بيصغر في الحجم بتاعه الشيست كافيتي كله. لما يبقى في حته في الشيست ما تبقاش فيه كونتينيوتي مع الشيست وول، وبالتالي بتتحرك بالعكس. ايه اللي بيحركها؟ مش الماسلز، اللي بيحركها هو النيجاتيفيتي او البوزيتيفيتي بتاعه الانتراثوراسيك بريشر. بمعنى ان العيان بيجي ياخد انسبيريشن المفروض بيتولد انتراثوراسيك بريشر نيجاتيف في الانسبيريشن عشان البيشنت يقدر يسحب هواء من بره نتيجة في التراكيوبرونكيال تري، وبالتالي النيجاتيف انتراثوراسيك بريشر ده اللي بيحصل الحتة الفليل سيجمنت دي اللي قلنا عليها 3 ريبس او اكتر مكسورة على ناحيتين او اكتر بتتحرك بتأثير النيجاتيف انتراثوراسيك بريشر، وبالتالي هنلاقي الشيست كله بينفليت لبره والحتة الفليل بتسق لجوه، بيحصل لها سكشن لجوه، ودي طبعا بيبقى ليه هيمودايناميك افكت على البيشنت. بيبقى فيه associated معاها lung contusion برضه، وبالتالي الساتوريشن بتاع البيشنت لازم يبقى تحت عينينا، oxygen saturation يبقى تحت عينينا على طول على مدار 24 ساعة. البيشنت يبقى monitorized يدخل ICU عشان لو حصل لا قدر الله deterioration بعد كده نقدر نتعامل معاها. الحتة دي زي ما اتفقنا ان هي مش fixed، فاحنا بنعمل لها management بعد كده هنتكلم عليه ان احنا بنعمل لها fixation ازاي. ده example ل chest x-ray العيان فيه chest trauma على الرايت سايد. طبعا دي x-ray posterior anterior review. عندنا ده الكاردياك شادو زي ما احنا شايفين، هو يعتبر average كاردياك شادو مش كبير ولا حاجة. لو جينا نبص على الريبس كلها، طبعا الريبس فيها دي كلافيكلز، اوكي دي السكابيلا. نيجي نبص على الريبس بتبقى جاية الدايركشن بتاعها في العد بتاعها واحنا بنعدها من posterior للانتيريور زي ما احنا شايفين posterior للانتيريور. ولازم وانت بتبص على الاكس راي في عيان تروما تاخد الريبس واحد واحد وتبص عليهم. ده فيرست ريب وتشوف الاتشز بتاعته اللاين بتاعه الانر بوردر والاوتر بوردر بتوع الفيرست ريب كونتينيوس مع بعض ولا لا. بعد كده تاخد كل الريبس ليها ابر بوردر ولور بوردر، ما عدا الفيرست ريب بيبقى فلات فبيبقى له انر واوتر بوردر. تمام. هنيجي نشوف الريبس. ادي الريب الاول تمام، الريب التاني تمام، الريب التالت تمام، ده الانتيريور بتاعه. الريب الرابع، الريب الخامس، الريب السادس. فلو جينا شوفنا هنا المنظر ده هنلاقي الكونتينيتي بتاعة الأبر بوردر واللور بوردر حصلها ديسربشن في الحتة دي مكان الفراكشر، يبقى إذا العيان دوت فيه فراكشر ريب. ده how to count the ribs. زي ما قلنا الريبس بيبقى لها directing من posterior للانتيريور، من السباينز ورا تبدأ تطلع لقدام علشان تعمل فيوجن مع الاسترنم والمانيوبريم. Here is the first rib. When we count from posterior, as we said before, that's the first one, that's the second one, the third one, fourth, fifth, sixth, seventh, eighth, ninth, and 10th rib. 10th rib is not evident here in this X-ray. On the left side, if we count it here on the anterior aspect, so the first rib anteriorly is here. There's the inner border and the outer border. Second rib is here anteriorly. Third rib is here anteriorly. Fourth rib is here anteriorly. So all the ribs are directing from posterior to anterior, downward and forward. So the level of the first rib here, for example, is lower than the level anteriorly, is lower than its level posteriorly. For all the ribs, it's the same. Here the first rib posterior and here the first rib anterior, so that's because it's directing anterior, forward and downward. Directing forward and downward, sorry. Now we will speak on a definition, etiology and management of pneumothorax, hemothorax and chylothorax. These are the most common types of trauma associated with chest trauma, or the most common pathologies associated with chest trauma. Firstly, for the pneumothorax, definition of pneumothorax, hemothorax, chylothorax, it means collection of that issue or that part in the pleural space. For example, definition of pneumothorax means collection of air in pleural cavity. Pneumo means air. Okay. Definition of hemothorax means collection of blood in pleural cavity. Chylothorax definition, its definition is collection of lymph or chyle in the pleural cavity, and as we mentioned before, is due to injury of lymphatic duct. Clinical presentations, this like a scheme, so you can just put it in any clinic presentation of any type of pathologies that we mentioned before, with a change of some points according to the pathology itself. For example, we have a trauma, so we have chest pain, dyspnea due to compression of the lung by air in case of pneumothorax, blood in case of pneumothorax, chyle in case of chylothorax, or lymph in case of chylothorax. Okay, signs. In science, during examination of the patients, so you have inspection, percussion, auscultation. You have to follow all of these items. Inspection shows decreased movement of the chest wall on the affected side. If there is pneumothorax, hemothorax, chylothorax, it's the same for all. But on percussion, there is different resonance according to the injury that is present, according to the pathology that is present, and a decrease or absent breath sound that's in all of them. Tachycardia and hypotension in case of hemodynamic instability. Let's see. In pneumothorax, for example, as we mentioned, dyspnea, chest pain is the same. Decreased movement of the chest wall, hyperresonance on percussion because that's air. So on percussion it gives a hyperresonance, decrease or absent breath sounds, tachycardia and hypotension in case of tension pneumothorax. Tension pneumothorax means collection of air in the pleural space. That means pneumothorax. It reaches tension when there is shift of the mediastinum to the opposite side that causes kink of the great vessels. The venous drainage of the heart will decrease, so the cardiac output will decrease and the patient developed hypotension. Hemothorax, the same as there is There will be dyspnea, chest pain, signs, decreased movement of chest wall, dullness or percussion. So any associated, any pleural effusion that's present, it will give dullness or percussion. So we can predict that there will be dullness and percussion in case of hemothorax, chylothorax, or any other type of pleural effusion. Okay, decrease or absent brief sounds according to the amount also of the hemothorax. Tachycardia, hypotension in case of shock if there is massive hemothorax. Chylothorax, the same, dyspnea, chest pain. This is the symptoms of patient. Signs would be decreased movement of chest wall, the same. Dullness on percussion, because that's effusion. Decrease or absent breath sounds. Tachycardia, hypotension in case of shock. Investigation, chest trauma. The first important investigation is a chest X-ray that will give you an image what's happening inside. Chest X-ray, you can detect chest wall fractures, the number and the type of fracture that is present, and the site of fracture that's present. Okay. Pneumothorax, it will present as jet black translucency. We will see an example for each of these. Hemothorax, it gives a homogeneous opacity, obliterating the costophrenic angle and rising toward the axilla. That if it's mild, just mild or moderate or severe, it has a grades according to the amount of the hemothorax collected. In case of severe hemothorax, there will be shift to the other side because of compression of the mediastinum to the other side. Okay, heart and great vessel injury will show an enlarged cardiac solid and widened mediastinum because of mediastinal hematoma, mediastinal hemorrhage. So if there is bleeding in the mediastinum, it will give wide mediastinum. Enlarged cardiac solid that results from pericardial effusion, hemopericardium I mean, in case of trauma. So it gives you, chest X-ray gives us an impression what's happening inside the chest. This is a previous X-ray that we saw before, showing fracture rib. And here how we count the ribs, as we mentioned also before. This is an X-ray giving an example of fracture rib on the left side. This patient has chest trauma with fracture rib on the left side with mild hemothorax. I say here hemothorax and not pleural effusion because it's first impression you get from the X-rays, the fracture rib. So it's a trauma patient. Show in a majority of patients it could be hemothorax because of the injury, but sometimes it's the fracture rib here is simple and maybe other cause for the effusion, maybe hepatic, renal, cardiac, whatever. But here, because we see the fracture rib, so we can say it's a pleural effusion, mostly hemothorax. This X-ray, that's the tension pneumothorax. On the right side, we see here jet black translucency, filling all the right thoracic cavity with the collapsed lung. Here is the lung border. This one is the lung border, collapsed lung, and the diaphragm is pushed on the right side downward with the pneumothorax, and here the mediastinum is shifted to the other side. Okay, so the shift of the mediastinum to the other side is the tension pneumothorax. Here is a pneumothorax and here is a tension pneumothorax. We say it as there is shift of the mediastinum and the hemodynamic instability. This is another X-ray, but it's of poor quality, showing obliteration of the left costophrenic angle was rising to the axilla, so it's a pleural effusion. That's an example of hemothorax or pleural effusion in general. This X-ray of a female patient showing right pneumothorax with air fluid level. Here is there is homogeneous opacity obliterating the angle. Okay, but it's associated with pneumothorax, so it gives an air fluid level. So the effusion is not rising to the axilla as we saw before, it's here an air fluid level. That is pneumothorax with a collapsed lung here, the hilum. The next investigation is the chest CT. CT computerized tomography of the chest, giving us a detailed image of the chest wall and thoracic cavity and its contents and each of the thoracic organs. It's better to do the CT with contrast, with IV contrast, so you can visualize the aorta, superior vena cava, pulmonary artery, and the great vessels and the cardiac chambers. All the cardiac chambers, you can visualize the mediastinum and can differentiate different lesions. During a computerized tomography scan, a thin X-ray beam rotates around an area of the body, generating a 3D image of the internal structures. For CT chest, we have two views, or two windows that we will describe. Here is the pulmonary window in which we can see the different parts of the lung tissue, and we can detect lung injury and in the lung parenchyma itself, as we see here. But for the mediastinal structure is not differentiated from each other. That is the pulmonary window. Another window is called the mediastinal window on the left side here, that shows the mediastinal structures, but we cannot see the parenchymal injuries or parenchymal lesions. So we have pulmonary window and mediastinal window. Pulmonary window shows the pulmonary injuries, and mediastinal window shows us the mediastinal injuries and the great vessels. Here is the aorta, ascending aorta. Here is the descending aorta. Here is the pulmonary artery, and here is the superior vena cava. This is the trachea, and this is the esophagus. Chest CT scan shows us has high sensitivity to diagnose pneumothorax, hemothorax, lung contusion, and atelectasis. Atelectasis means a collapse of a loop or the whole lung. Shows us aortic dissection, as we mentioned in the mediastinal window. Lung contusion appears in pulmonary window, as we mentioned. It's a parenchymal injury, so it's more evident in the pulmonary window. Aortic dissection, you can detect it in the mediastinal window. Here is a pulmonary window showing the lung parenchyma on the right side and the lung on the left side. The lung on the left side here shows pneumothorax collected on the left side, and there is some lung contusion on both sides here in the posterior parts of the lung. This is another chest X-ray, so we go for CT directly. This is a CT scan showing here. This is a mediastinal window, as we mentioned. So there's a pulmonary artery giving the right and the left pulmonary artery. Here is the ascending aorta. Here is the descending aorta. Here is the superior vena cava, and here is now we are going to show the cardiac chambers. Okay, what's positive here as related to the trauma is very mild pleural effusion on the left side here, as we see. In comparison to the right side, there is no effusion, so you have a very minimal amount of pleural effusion on the CT here, causing compression on the underlying lung. Okay, here is the same patient with pulmonary window. That's showing the pulmonary window. So the lung here shows some atelectasis or collapse of the left lower loop. Okay, under the amount of effusion, under the effusion on the left side. This is a reconstruction, bone reconstruction of the chest X-ray of the thoracic cage, bone reconstruction. So it gives us an impression of the thoracic bony cage and the lesion in it. Here, as we see, this is the manubrium sterni. This is the sternum. This is the foot. Here, clavicle, and here are the ribs. And this is scapula on the left side, and this is scapula on the right side. This one we see here fractures, ribs, multiple fractures of the 6th, 7th, and 8th ribs. CT also is important for us to differentiate between the free and encysted pleural effusion. Encysted pleural effusion means that the effusion is encysted in separate spaces, so it's collected by is surrounded by fibrous wheel, and it is not free like this image. Here is encysted effusion. Okay, mostly it's collected on the posterior aspect. If there is pleural effusion free, it will collect posteriorly, because the patient here in CT is lying on his back, so you will see the effusion posteriorly. Okay, in case of encysted effusion, you will see it on the you can see it everywhere, so it's encysted like here or here. It's like a pocket separate, it's not mainly on the posterior. This is another patient, 60 years old male patient, presented to the ER with severe chest pain of sudden onset. This was his X-ray. What's the diagnosis? Okay, it's not a trauma, just severe pain. As you see here, the aortic knuckle is prominent, and here we see like haziness or well-defined opacity in this area. We can expect that it can be like leaking hematoma or some sort of aortic injury, aortic lesion, I mean. This is another chest X-ray. This is a CT in a patient with chest X-ray that shows a widening of the superior mediastinum and a well-defined mass inferior and contiguous with the arch of the aorta. In this clinical context, this section of the arch of the aorta has to be excluded. Okay. In the CT thorax, in this one, for a patient shows the presence of aneurysm at the aortic arch with thrombus. Here is the aortic arch. Usually that is the aneurysm. Okay, it shouldn't be like that. The aortic arch should be like that. Okay, continuous with each other with almost the same diameter. Here is the aneurysmal dilatation, and this is mainly a thrombus in the wall of the aneurysm. Other investigations in chest trauma are thoracic ultrasound to detect hemopericardium and associated injuries. Okay, so if there is hemopericardium, so echocardiography, which is called the cardiac ultrasound, can detect pericardial effusion or hemopericardium and its amount and its clinical significance. Is it compressing the RV or right ventricle causing collapse of the patient, or tamponading or not? Lab investigations include blood type and cross matching. So if the patient needs blood transfusion, we can manage as fast as possible CBC, arterial blood gases, and coagulation profile. Investigations of pneumothorax, hemothorax, chylothorax, as we mentioned before, chest X-ray, CT, and others. So in each type we will discuss what will be further investigations of each type of the pathologies in chest trauma. For example, for pneumothorax, chest X-ray, as we mentioned before, the jet black translucency. CT will differentiate encysted pneumothorax from emphysematous poly and detect apical poly in primary pneumothorax. Sometimes in case of pneumothorax it's not traumatic and it's primary pneumothorax without trauma, spontaneous. We say it's spontaneous pneumothorax. That is in patients who are smokers, COPD, for a long time with apical bully. One of the bully may rupture and causes spontaneous pneumothorax without trauma. Sometimes in the bulla, if it's a large bulla, it gives in the X-ray. We see in the large bulla in the X-ray, we cannot differentiate it from encysted pneumothorax, so the CT is the solution for that. Other investigations in case of pneumothorax is arterial blood gases, so we can detect if any problem, clinical problem, or there is affection of the arterial blood gases, PO2, PCO2. Are they normal or not? Investigation of hemothorax. Chest X-ray will show us homogeneous opacity obliterating the costophrenic angle and rising towards the axilla as we saw before in the X-ray. CT will show us if there is any suspected if you suspect encysted effusion, so you will not see in the X-ray, you will not see the clinical, the typical image of the pleural effusion that's rising to the axilla and obliterating the angle. So you may see just collection in certain sides, for example the lateral chest wall or something like that. So you can see with the CT is it encysted effusion or is other lesion. Okay. Also CT will give us an impression of the underlying pathology. Others like aspiration and analysis of the hemothorax and aortogram. If you suspect aortic injury, you can go for aortogram. That will show us the course of the aorta and if there is a specific lesion for the aortic wall. Investigations of chylothorax and chest X-ray, it's the pleural effusion, chylothorax, so it's also homogeneous opacity obliterating the costophrenic angle and rising towards the axilla. CT, if you suspect encysted effusion, so you can do CT chest and to detect the underlying pathology. So if there is a chylothorax for any reason, not only trauma, you can find chylothorax due to a tumor compressing the thoracic duct or invading it. So you will have a leakage of chyle or lymph in the pleural space, causing chylothorax. So CT will give us an impression if there is associated pathologies that we can manage. Others, in chylothorax, we have to aspirate and analyze the fluid inside. If the triglyceride to cholesterol ratio is more than 1:1, it is chylothorax. Okay. This is an X-ray of the patient with right pneumothorax, and this X-ray of another patient, it's not the same patient. This is another patient with also a pneumothorax or hemothorax before. This is an intercostal tube that is inserted to drain the collection hydrothorax or pneumothorax, and we see here the lung is completely expanded after insertion of the chest tube. Treatment of chest trauma. As always in trauma, management begins with establishing of the airway, breathing, circulation, ABCD, and all of you know it. Rib fractures, effective pain control to decrease the pain, because rib fractures are very painful. So with inspiration and expiration, the little movement of the chest wall, there is pain. Okay, so pain control either oral with tablets, parenteral analgesics, intercostal nerve block, or epidural analgesia. That depends according to the number of ribs fractured and the patient tolerability to pain. Okay. Early mobilization and aggressive chest physiotherapy. Why we do that? Because patients with fracture rib feel the pain with every inspiration and expiration. So the patient chest wall movement is limited during inspiration and expiration, and the underlying lung is not well expanded and deflate during the respiratory cycle. That leads to accumulation of secretions inside the chest, okay, and may cause atelectasis or infection in the lung. So early mobilization and aggressive chest physiotherapy helps the patient to uh, discharge or expectorate any secretions that can be accumulated in the chest, in the tracheobronchial tree, so we avoid atelectasis and lung infection. Flail chest. As we mentioned before, flail chest means involvement of 3 or more consecutive ribs fracture in 2 or more places, which produce a free-floating, unstable segment of the chest wall. Treatment is treated at fracture rib associated with pulmonary contusion. So, treatment as fracture ribs by analgesics and physiotherapy, and treatment of the pulmonary contusion that will be ICU admission, monitoring of PO2, monitoring of blood gases, um, and monitoring of the hemodynamic status of the patient. This may necessitate endotracheal intubation and positive pressure mechanical ventilation. The flail segment, as we agree, is a loose segment, so the aim is to fix it. We have to fix it externally or internally or both. How to fix it externally? With a plaster. How to fix it internally? With positive pressure ventilation or both. So its fixation will decrease its movement during the respiratory cycle, its abnormal movement during the respiratory cycle, okay, which is paradoxical movement and is not the physiological one. Pulmonary contusion is managed by pain control, pulmonary toilet, and supplemental oxygen, and may need mechanical ventilation of the blood gases if the arterial blood gas is deteriorating. Injury to the tracheobronchial tree is managed by thoracotomy and repair. Treatment of pneumothorax. General measures include supplemental oxygen, so you can give the patient mask oxygen or nasal cannula, and chest physiotherapy. Specific treatment is a chest tube insertion to drain the air collected inside with the underwater seal, or thoracotomy and repair the cause. This step is not done from the primary presentation of the patient, but thoracotomy and repair of the cause if there is massive or persistent air leak more than 7 days after insertion of the chest tube. Okay. It can also be managed with the video-associated thoracoscopic surgery, which is less invasive, which is called VATS. VATS, video-assisted thoracoscopic surgery. Treatment of hemothorax. General measures are blood transfusion if there is a massive hemothorax and the patient lost a big amount of blood, so you have to replace it, and chest physiotherapy. Specific treatment, chest tube insertion should be a wide bore cannula and dependable, so because of the effusion is usually collected in the dependent area, and it should be wide bore cannula so the blood will not clot and obstruct the tube. Next step is thoracotomy and repair the cause if there is massive more than 100 ml initially, or if there is clotted blood. For example, if you insert an intercostal chest tube in a patient with a hemothorax and the patient drained an amount which is not a massive amount, less than 1 liter initially, okay, but the chest x-ray still showed a collection inside, it's mostly a clotted hemothorax, and chest tube is not draining anymore, so you have to do thoracotomy and explore the patient to remove the clotted blood and check what's the cause of bleeding, of that massive bleeding. Okay. Video assisted thoracoscopic surgery, which is less invasive, can also be used to drain the blood and detect the problem inside if it can be managed. Treatment of chylothorax. General measures are TPN chest physiotherapy. TPN means total parenteral nutrition because the chyle is, or the lymph is generated from the GIT, and because in response to the fatty meals. In these cases, with the chylothorax, we usually transfer the patient to a total parenteral nutrition. So the patient stop oral feeding, so stop stimulating the GIT, stop formation or decrease the formation of the chyle. Okay, so we can decrease the leaking side, decrease the leakage of chylothorax from the leaking side, so it can help in repair or in healing, spontaneous healing of the thoracic duct. Okay, and chest physiotherapy, as we mentioned, to decrease intrapulmonary collection of secretions, intratracheobronchial tree, I mean. Specific treatment: chest tube insertion to drain the chyle and give a chance for the lung to inflate. Thoracotomy and repair of the cause if there is still drainage more than 1,500 ml per day for 5 consecutive days. In this case, you have to explore the patient and ligate the thoracic duct through right thoracotomy, low right thoracotomy. So you will get the thoracic duct just above the diaphragm, and you can ligate it, so you decrease its drainage, or decrease its drainage, yes, through the tear. Because the normal pathway of the chyle is from the cisterna chyli that is formed under the diaphragm, and then it passes to the thoracic duct, then it passes to drain in the connection between subclavian and internal jugular vein on the left side. So it's from down upward. So we have to ligate it supradiaphragmatic, just supradiaphragmatic. Okay, we can do it also using VATS, video assisted thoracoscopic surgery, which is less invasive, as we mentioned. Cardiac injuries. It may be penetrating cardiac injuries that cause cardiac tamponade. What's the definition of cardiac tamponade? Is accumulation of fluid in the pericardium resulting in marked increase in the pericardial pressure and then decrease in cardiac output and hypotension. There is a diagnostic criteria for the cardiac tamponade, which is called big triad. Okay, that's include 3 things. The first one is congested neck veins, distant heart sounds and or muffled heart sounds, and the last one is hypotension. That's diagnostic for cardiac tamponade in a trauma patient. Investigations: will do chest X-rays that show us flask-shaped cardiac shadow in case of pericardial effusion, massive pericardial effusion, and echocardiography is diagnostic of the pericardial hemopericardium or pericardial effusion. The treatment is pericardiocentesis, so we remove a small amount of blood, results that will result in immediate hemodynamic improvement in tamponade, if tamponade exists. Okay, so in case of tamponade, just small amount of pericardium will release. If release a small amount, so the patient will improve, just improvement at once. The next step is thoracotomy or median sternotomy and pericardiotomy and surgical repair of the cause of trauma, either a stab, heart, or something. So you have to open and explore the patient either through thoracotomy or median sternotomy. That depends on the site of the injury, okay, and the better exposure will be thoracotomy or median sternotomy according to the site of the injury of the patient. Blunt cardiac injury, which is called also myocardial contusion. that range from mild trauma associated only with transient arrhythmia to up to rupture of the valve or the interventricular septum or the myocardium, which is called cardiac chamber rupture. Management. The management include clinical manifestations that range from just chest pain to cardiac tamponade and shock. ECG may reveal arrhythmia or ST segment changes. Echocardiography may reveal disturbance in the cardiac motion in the form of cardiac motion abnormality. Treatment is conservative in case of cardiac contusion. Diaphragmatic injuries. More commonly diagnosed on the left side, or more commonly it's happening on the left side, because the right diaphragmatic cupula is supported by the lever that obliterate the defect or protect it on the right side. Okay, so it's 84% on the left side and 14% on the right side and 2% bilateral diaphragmatic ruptures or diaphragmatic injuries in case of chest trauma. The diagnosis include clinical presentation in the form of pain, respiratory distress, and abdominal complaint. So the pain is due to chest trauma, respiratory distress. That's because the abdominal organs go through into the thoracic cavity and cause compression on the lung. With the right side diaphragmatic injury, the liver will compress the lung on the right side, and on the left side it will be the stomach, spleen, or abdominal organs compressing also the lung and causing dyspnea and respiratory distress. That's in acute cases mostly. Delayed cases, abdominal complaint, by chance abdominal complaint may be due to intestinal volvulus or obstruction that cause constipation, vomiting. So it's related to the obstruction of the abdominal of the intestinal loop in the chest cavity by the opening in the diaphragm, the borders of the opening of the diaphragm. Delayed cases usually presented with intestinal obstruction or gangrene. Okay, sometimes there is a small tear. Primarily at the presentation of the patient is a small tear, and it can be missed or not diagnosed in the primary presentation of the patient. So the patient comes with just chest trauma and chest x-ray initially is free, but because of the positive intra-abdominal pressure and the negative intrathoracic pressure, with time the tear may increase in size. Okay, there is a small stab, for example, including the diaphragm. Okay, but there is no diaphragmatic herniation or no passage of the intestinal abdominal content into the thoracic cavity. That's because of this, the tear is small. So the patient may present initially with just pneumothorax, and you can insert chest tube or hemothorax and chest tube, then removed. Chest X-ray is completely normal. After that, the chronicity of the disease or the chronicity of the tear, because it's missed, we didn't diagnose it initially. So with the increase of the intra-abdominal pressure and the negative intrathoracic pressure, the tear starts to increase. Okay, and the abdominal contents start to protrude in the thoracic cavity, and adhesions started to be formed in the thoracic cavity, followed by intestinal obstruction or gangrene, because the intestinal loops are moving. That may cause volvulus and obstruction of the blood supply to the intestine and gangrene. That's in chronic case or delayed cases. Treatment. If we diagnose it initially, so we have to explore the patient and suture the tear in diaphragm through laparotomy if early, or through thoracotomy if late presentation. Why? Because through acute cases, if it's early diagnosis, it has to be done through laparotomy. It's easier to be done. That's to reduce abdominal contents from thoracic cavity to the abdominal cavity, it's easier to do it without volvulus, without rotation of the intestinal loops. That's one issue. And the other issue is that during the chronic cases, it's better to do it through thoracotomy, because we expect, as we mentioned, that there will be adhesions in the thoracic cavity between the intestine and the lung and the chest wall, so it's better to be done through thoracotomy. Or if the tear is not accessible through a laparotomy, in acute cases, we can also do it through thoracotomy.